Okay, well, let's get started. Since we have just 1 hour today, I don't really want to cut short the time for our discussion, and welcome everyone to this first of our World Hepatitis Day webinar series, our global discussion series, Hepatitis Can't Wait, Accelerating Action. And just before we get started, next slide, please. This meeting will offer simultaneous interpretation from English into Spanish. So on the bottom of your screen, maybe go to the next slide. On the bottom of your screen, you'll see an interpretation button. And if you click on the interpretation button and choose the language that you wish to hear, then you'll receive the correct language or the translation when the time is right. Terrific. So welcome again to this exciting session. I think we really have a global list of participants from right around the world. And the idea of having this kind of online discussion as opposed to like a traditional webinar is to really take what's often the most interesting part of a webinar, which is the Q&A or this discussion at the end, and actually make that the main feature of our event. So there won't be any presentations today. And we do have a few featured participants who are going to give their view on the 3 questions or the 3 discussion points that we kind of outlined in the description of the webinar. The first of which is overcoming the persistent barriers to testing, treatment, and prevention. The second is accelerating decentralization and to bring services closer to the communities who need them. And the third part is accelerating hepatitis elimination through cancer prevention, reduction of non-communicable diseases, and the transformation for universal health coverage, as well as the integration with other disease areas. So we have some great featured participants, but we really want to hear from all of you throughout the webinar. So please feel free to raise your hand at any point, and we will unmute your microphone and we'll make it possible for you to turn on your video. If you have a comment on what's been said, if you have another view on the topic that's being discussed, or you have an example from your own work that you think will help other organizations accelerate their response to hepatitis elimination, we really want to hear from you. And the success of this webinar will really be on the participation from all of you. So don't be shy. And so let's get started. So I think we'll start with talking about kind of overcoming some of those barriers and what really needs to be done in terms of specifically hepatitis B and C, what really needs to be done to kind of move things along. And I will begin with Gitten from Treat Asia. And could you tell us what you think, what needs to be done to accelerate action, especially around hepatitis B?
Thank you so much, Carrie, and a very good morning or evening or afternoon to everybody in this webinar. I would not want to. This is a round table, so I would not want to give suggestions or what would work according to me. But I would like to place out some of the things which perhaps we have missed, and also to go through some of the recent or a little bit a decade past of history. If we recall, the first viral hepatitis resolution at the World Health Assembly was in 2010. And then it was the first resolution, we call it as a viral hepatitis resolution. It was again reinforced in 2014. And then another 2 years later in 2016 was when we got the global health sector strategy and we started talking about elimination. And we talked about elimination targets, both for hepatitis B and hepatitis C, as 90% reduction in terms of new infections and a 65% reduction in terms of mortality. So that's what we have been working on towards achieving. At the same time, as recently as last week, we have seen a guidance that has come out for country level validation of elimination of viral hepatitis. So that is above or on top of what we have seen from 2014 onwards, a gradual evolution of WHO guidances, mainly which were based on screening and on treatment of viral hepatitis, both B and C. B has been a little bit behind in terms of evolution. We haven't seen an update in terms of treatment, but in terms of hepatitis C, we have seen from 2014 and at 2018, the first one is 2014, 2018, we have seen a treat all recommendation with a pangenotypic regimen. So that's a good move in terms of policy or guidelines related changes in the case of hepatitis C. We are yet to see that on hepatitis B. Now, let's relook. Now, 71 million was for people living with hepatitis C, chronic hepatitis C. That was what was reported earlier. 257 million again on hepatitis B. Now that has been revised as new estimates with 58 million people living with hepatitis, chronic hepatitis C. At the same time, hepatitis B has gone up to 296 million. So the new revised estimates has given a much more higher number in terms of people with chronic hepatitis B. But you know, for all the good reasons and with all the investments that has gone in, we have another infectious disease, which is what we know as HIV, and there has been international programs that has been running for the last 25 years odd or so in almost every part of the world. And they also have had targets. I'm not trying to segregate infections or diseases here and to talk about siloed vertical programs. But what I'm trying to say is HIV has gotten very much far ahead in terms of both availability of medication, development of policies, at the same time, you know, investments and community participation from people who are living with HIV. And the targets, they also had targets which we used to call as 90-90-90. Recently, it has been upgraded, but there has been a very good achievement in terms of achieving those targets. And globally, 81% of people knows their HIV status, and 82% of those who knows their status are on treatment. So if we compare this, now I'm coming back to our viral hepatitis, we have hepatitis C 21 as per the last progress report from WHO. We have 21% diagnosed for hepatitis C, and we have only 13% treated. In the case of hepatitis B, only it is 10% that has been diagnosed and 2% has been on treatment. And we lost 650,000 people living with hepatitis B last year. And this is because of, you know, what we also call as sequelae, because of different conditions related to hepatitis B. But why is it that? Is that something which is acceptable? This is why I want to start this conversation. Why is it? Earlier, we used to talk about non-availability of medication. Tenofovir is an extremely effective medication that is being used not only for treatment of HIV, but for prevention of HIV. I mean, in PrEP, we use it for tenofovir as a component and a part of a regimen within the pre-exposure prophylaxis. It is also now used for prevention of hepatitis B, vertical transmission from mother to child. So the mother is now, besides the vaccine that would be given to the child, we are now also using tenofovir. This is no longer in patent in anywhere, almost every part of the world, including in developed countries. And in many countries, this cost, according to the Global Fund pool procurement, it's cost approximately $24 per person per year. And yet, and there are also many data which shows similar to HIV to show that the lower the viral load, the longer the person lives. And why do we use medication for? to lower down the viral load, at the same time, control the infection or control the transmission. And there are innumerable number of data that has gone in, or a number of data, I won't say innumerable, but a lot of data that has shown that treatment is indeed useful. But we don't have that. We still have, for hepatitis B, a treatment guideline, which is of HIV 25 years ago, which used to say that unless your CD4 count is at 250, or you have a stage 4 opportunistic infection, you will not be on treatment. Similarly, for hepatitis B at this point, HIV, we treat irrespective at the moment. That's a global recommendation. But for hepatitis B, we have a situation where we say, okay, you come back after this much time if your viral load is not above 20,000 IU/ml. But if you're cirrhotic, you can be on treatment. I mean, and how many people comes back? And you'd be called back every 6 months. How many people would come back? Why did we lose 650,000 people last year? How many? And we can get this, we can get segregated across which country lost how many people, at what age, what is the trend of liver cirrhosis because of hepatitis B, what is the trend of liver cancer because of hepatitis B and related mortalities. We can get all of that. Why is it that we are losing so many people when we have a drug which is costing as low as $24 per person per year? It might not be everywhere, but many of the places where it is global fund procurements are, and at the same time, which is outside of intellectual property, and it's widely available in generic form. Why is it that we continue to lose so many people on hepatitis B? And I would like to have a conversation on that front, in line with the global target of reducing 65% of mortality by 2030, which is 9 years away. Over. Thank you.
Thank you, Gitan. So many great points there. And I think it's the kind of research gap that's also like a big issue here, right? Like for HIV, like treatment guidelines really changed when like the partner study came in and they could show that early initiation of treatment had a beneficial effect to long-term health outcomes. And I guess those kind of studies are really lacking in hepatitis B.
Yes, I think that is lacking. A lot of the focus at the moment is on the cure research. And I think that is also needed. We're likely to have very good medications which could potentially cure in the next 3 or 4 years, and that there are very good medications that are emerging. We don't know the final results. We will know obviously when the trials are completed and we establish how effective these medications are. But also that there are a lot of data, which indirect data, for example, which or evidences which we could rely on, like a lot of the studies that has come out from our region, for example, from Taiwan, the studies that has come out from there in terms of how viral load and for example cirrhosis development or HCC or related mortality is related. So those are some of the things. My point is a lot of this is clinically driven, which is necessary. But what are the values and preferences of people living with hepatitis B to enable to put their point across to say whether I want to be on treatment or not? I don't think that kind of a study to understand values and preferences from a patient point of view to say, what is it that would be beneficial for me, or what have I understood after understanding, full situation, both pros and cons of being on treatment. I think that is a big, huge gap to carry over.
Yeah, I think that's a really good point. I mean, we have discussions around treat all, amongst doctors or amongst, hepatitis professionals, but we don't really know how, people who are living with hepatitis B, what their view of treat all or those kind of new strategies would be. So I think that would be a really important piece of work for sure. There have a few hands up. Maria, would you like to contribute, please?
Ahora sí, ahora sí se me escucha. Quería aportar que en el año 2019 hicimos un estudio en América Latina sobre el problema de que había muy pocos tratamientos para hepatitis B otorgados a las personas afectadas. Y allí nos encontramos con dos dificultades básicas. Por un lado, que no todos los médicos saben cuándo prescribir el tratamiento para hepatitis B y cuándo hay que hacer solamente el seguimiento y control. Y por otro lado, el tratamiento para hepatitis B está considerado de bajo costo. Entonces no ingresa en algunos programas gubernamentales para cubrir la medicación de alto costo. Pero ese bajo costo suele ser mucho para gente que no tiene dinero. Y por otro lado, sí pasa lo que tú comentabas, que solamente cubren 100% el tratamiento para personas con VIH. Entonces ahí nos encontramos en un grave problema también en América Latina. Y quería aportar esta mirada, que es un poco lo que hemos visto, porque creo que sería interesante trabajar sobre estos dos puntos. Gracias.
Great, thank you. And I think, Manal, you put a question in the chat. Would you like to unmute your microphone and ask, please?
Hello, everyone. I was just wondering why for pregnancy, there's a cutoff limit of viral load being 200,000 instead of the 2,000 or 20,000 limit, which is recommended by international guidelines. I was just wondering why, because they are more vulnerable, and being pregnant means your immune system is lower and greater susceptibility to transmit the infection to the baby and all of that. I was just wondering why, how come, what's the rationale for choosing that cutoff point, the cutoff limit of 200,000?
Great, thank you. Gitin, could you speak to that?
I was not a part of this GDG on the so I am really not aware. I was aware that 200,000 was the IUML, but I was not part of the GDG, and I haven't seen the meta-analysis that the group had actually seen. So I don't have any comment, but I think the guidelines, the rationale of this would be, I'm sure, in the guidelines document in the rationale section below the recommendation.
Thank you.
Excellent. And Charles, I see there's a question in the chat. Maybe if you want to unmute your microphone, would you like to say it? Or a comment, I guess? Okay, well, maybe I can just read it. Charles is from Ghana, I believe. And he said the difficulty is that the cost of viral load determination in itself is too expensive for the average person to afford, given it's not part of the health insurance in most low and middle income countries.
I mean, absolutely agree with this. So where do we come to a consensus? What is it? So the DNA is much more expensive even than the Hep cRNA. So that is one. Unavailability of the DNA platforms is another issue. So if we're going to fix everything on the DNA, there are, so somebody is, say for example, 1500 IUML 1500 viral load and doesn't come back, you don't need to be on treatment. You're not showing any symptoms of being on being cirrhotic. A lot of people are advised to come back. 6 months is the time when they're advised to come back, and people don't just come back. Either they're having difficulties coming back, or there's no way to track some of those as lost to follow-up. Some of them have just passed away because there are also data to show that the progression could be really, really fast. So Charles's point in Kerry, you were referring to, I mean, this is the current guidelines, although it's targeted because it's WHO. It's for low and middle income countries. There is no way that at least the hepatitis B1 is not possible to and And also, if somebody is cirrhotic, then you're lucky in that sense. You know that you're going to be on treatment throughout your life. So you're certain. You don't have to continuously monitor many things. But if you're not, then you would have to be, you would continuously have to be monitored. And low and middle income countries are not in a position to absorb that. And probably that is one of the reasons, given the cost, that is one of the reasons why there is so less of political will, that if we have so many number of people who are going to come up asking for this treatment, and we have to test them and give them the treatment at the same time, continuously monitor them, perhaps, economy-wise, that's something not going to be very much feasible for low and middle income countries. That could be there also. It's not a cure, it's just going on, monitoring. Over.
Excellent, thank you. I see there's a few more hands up, but I just want to broaden the scope a little bit wider. So if you do have any comments, please put them in the chat and we'll capture them there, and maybe we'll be able to circle back to them by the end. So I just want to bring in Sione from Harm Reduction Victoria and kind of broaden the conversation now to hepatitis C, and of course, one of the most important groups, which is people who use drugs and harm reduction services. So Sione.
Thank you very much, and thank you for having me here. It's great to be part of this. First of all, I'd just like to take a couple of moments at the start to acknowledge the traditional owners of the land on which I'm coming to you from in Melbourne, Australia. So it's the Wurundjeri people of the Kulin Aboriginal Nation. I'd like to acknowledge all First Nations people who are present as well. So clearly I'm coming to you from Australia, and in many ways, we're in a, a relatively good position at a population level, I suppose, in terms of testing and treating hepatitis C in particular. But it's definitely the case that things have been slowing down a little bit, and there are some definite challenges, especially for treating people who inject drugs in particular in Australia. And the goal of elimination by 2030 is looking very challenging at the moment for a range of reasons, which I'm sure we'll talk about and we know about. And I don't have a huge amount of time, so I just wanted to really attack, I suppose, and talk about 3 or 4 key things at some different levels that I think might be really important for us to consider and, if possible, impact and affect. And so I suppose, at the higher society level, and certainly, we're pushing, it's going to be pretty tricky to manage this in the next few years, but I really think it's important to attack and defeat the stigma that's related to hepatitis C. And in particular, the stigma related to injecting, which is the the primary affected population for hepatitis C in Australia, at any rate. And that stigma around Hep C and around injecting drug use that attaches to people with hepatitis C, and attaches to people who use and inject drugs. Really impacts in a whole range of ways that we don't have a huge amount of time to go into here, but it's insidious and it's tricky. It's a layered thing. It impacts on, as we know, I'm sure people impacts upon the affected community and our likelihood of actually accessing health treatment, because very often we've been discriminated against in the past, and it impacts on clinicians and it impacts on healthcare providers who often don't want to and are unwilling to treat people or be involved in hepatitis C care at all, actually. That's clearly a big societal issue and won't be defeated quickly, but we absolutely have to attack it and think about ways to defeat it. And that will range from individual level sort of training and things like that, right through to considering things like decriminalisation, because a huge amount of the stigma attached to illicit drug use in particular is related to the fact that it's a crime in most parts of the world. On a clinical level, I think a really important thing that we need to do to accelerate our way towards the goals of elimination of hepatitis C is really to simplify access to care. It's that simple in many ways. In any way possible that we can, ideally we need to make it easy for the affected community to access hepatitis C testing, treatment and prevention, and ideally for there to be sort of one-stop shops and an opportunity for people to access treatment and reflex to treatment as soon as they know that they are positive, so that we can make it as simple as possible for people. And increasingly we are getting the tools to be able to do that with point of care testing and obviously pan-genotypic DAA Hep C treatments as well, which should really help with that. And we need to really put our mind to eliminating as many of the tricky parts of the cascade of care where people, especially marginalized people, tend to fall through the gaps in the cascade. So related to that, finally, I suppose, is the individual, is a sort of an individual level issue. And that's, I think, that we need to understand that for many people who inject drugs in particular, and many people who are highly marginalized and are affected by hepatitis C, for many of us, to be really honest, hepatitis C elimination in particular, but even hepatitis C treatment and care is just not a priority in the same way that the struggle for food, the struggle through criminal justice systems and prisons, the struggle through for housing and shelter, and a whole range of other social issues in particular are a far greater immediate priority, obviously, for people than hepatitis C treatment, and for really taking care of something that for many people is a little bit hard to understand fully and a little bit tricky to understand its impact. You know, when we're talking about an asymptomatic disease for many people, the prioritizing of Hep C treatment and care is very tricky for people who have a range of priorities. So really, for many of us in the community, particularly people in marginalized communities, for many of us will say that sure, Hep can't wait, but unfortunately nor can my methadone or my rent or my groceries and so on. So how do we balance, you know, today's needs, people's today's needs with the long-term needs, both of the population and of individuals? So, you know, obviously there's a whole range of other things that we need to do, and I think they're getting asked some really good questions, you know, around why is it kind of okay for people to be, you know, for governments in particular to appear to allow our communities to be dying ultimately from these diseases, when we know that there are things we can do to stop them. They're not simple, but it's absolutely possible. I'm not sure that politicians and governments in particular really fully understand the scale of the issue, and that's something I took from Geetan's talk, and I agree with 100%, I think.
Thank you so much. And that's such a powerful message. It's like, why is it acceptable that governments around the world are letting all of these people die each year from you know, mortality that could be prevented very easily and for quite a low cost in most countries? It's quite incredible. So I think if you have any comments around hepatitis C or any of those issues, please do put it into the chat. But for right now, I'd just like to move on to our next featured participant, which is Manal from Sierra Leone. Manal, I'll let you introduce yourself and tell us about the great work that you're doing there, please.
Thank you very much. Good evening, good morning, good afternoon, everybody. I'm glad to be here and to be part of this webinar. Yes, I'm from Sierra Leone. I'm a pharmacist, and in the past, I've been involved in community awareness raising and sensitization, free screening for hepatitis B, particularly because it's the most prevalent among the viral hepatitis, and to also advocate on the uptake of hepatitis B vaccination, that is offering preventive services on a daily basis at the community level or at my community pharmacies. And also mass media sensitization, I've been involved in that. So owning community pharmacies across the country, I'll say I'm the first that actually incorporated public health services like screening to enhance testing, or to break the barrier that has to do with testing, screening. We also offer free education on hepatitis. We also do free consultation for those infected with the virus and do appropriate referrals. We also support them to resolve drug therapy problems on a daily basis. So also recently, I've written a policy brief to the first legal research organization in Sierra Leone to enhance or to fast track the birth dose introduction in Sierra Leone. And for this year, in commemoration of World Hepatitis Day, we started our campaign in May by training 314 nurses so far on viral hepatitis, mainly to ensure or to educate those nurses or healthcare professionals about the criteria involved in commencement of treatment, and also of the importance of prevention of mother-to-child transmission, because that's our main aim for this year. So after that, we have completed the training. This week, we are starting screening of pregnant females enrolled in those 10 community health centers. And that will sum up to free screening of 745 pregnant females. So already from small studies, we already know that 11% of pregnant females are infected with hepatitis. And we would like to use this platform also to develop a research to know among these 745 pregnant females, how many of them are actually infected with hepatitis. So mothers that are, we're going to ensure that babies born from infected mothers also are going to be vaccinated for free. And also one thing that I'm so excited about is that 6 posters of Hep Can't Wait also have been displayed in billboards across 4 areas in the capital city of Sierra Leone. So our next move after commemoration of World Hepatitis Day, we would like to decentralize services where being a pharmacist, I would like to actually advocate to all community pharmacies to start and to encourage them to actually screen as much population as possible to break the barriers to testing, and also to encourage the population to be vaccinated as a preventive service. Thank you very much. That's all I have for you now.
Thank you so much, Manal. And I remember we first met at an African conference in 2019. I think before you set up your foundation, right? And we talked about Sierra Leone and the difficult situation people have there. And then after that meeting, you went on to start your foundation and extend your work.
It was an inspiration, yes. But I've already been in the fight since 2014. So yes, but that summit was an inspiration to actually have my own foundation.
So I think it's incredible, especially for someone like a pharmacist to kind of also expand the work that you're doing, because you recognize that need, right? So, I mean, what advice would you maybe have to other people who see a great need in their communities in order to, get something started? Or maybe people that are professionals that want to kind of expand their work and have more of a public health impact?
Yeah, I would say whatever kind of medical service or health service that you are providing, it's good to focus on a niche, or to actually know what's happening and get to know all the barriers involved in whether it's testing, diagnosis, and try to find ways to find cost-effective mechanisms to actually serve your community.
That's terrific. Thank you so much. Thank you. And I think now we'd like
Thank
to move from Sierra Leone to Pakistan and hear from Shamon, who also has a great story of identifying a need within the community and really kind of stepping up and do something about it. So Shamon, would you like to take the floor, please?
So much. I am very thankful for everyone to give me a chance to listen. I would like to start from how I get to know about the hepatitis. Even we are living in a very good place and we don't understand this word. But what happened once my sister actually, she was 32 years old. So she was very weak. She was get so much sick. So we went to the doctor and we asked him, so what happened to her? So when she was in the final stage, so the doctor said to us that she has got hepatitis B. And we say, what is hepatitis B? Because we don't know about it. So at the last stage, he said, the doctor said, the liver of her has been dried and is not functioning well, and there is no liver transplantation in this country, Pakistan, right now. So we cannot help you, so you can pray just. So we were very worried about it, and with very sad moment, I can say, in the age of 32 years, my youngest sister has died in front of my eyes. I cannot, you can say, forget every moment that I done everything to save her, but we couldn't, because she was on the last stage. She on the hepatitis B and C, and the liver has stopped the function. So finally, I got. I was a university student at that days. So the university asked me, everyone, to do a research project. So they asked me, what do you want to research on? So then I say, I would like to research upon the hepatitis B and C. The hepatitis, what is hepatitis and how they're affecting Balochistan, Pakistan, and how is affecting my life, my family. So I start a search about it, and I made a team, an organization about it. So I found that as I taken the research, that according to the hepatologist, Dr. Huma Qureshi, Executive Director, Pakistan Medical Research Council, she said the occurrence rate of the hepatitis B was the double of the national figure in my province. So when I come to know that the hepatitis B is that much prevalence rate is that much high, 4.3. So then I made a interviewed and a research team, a pilot testing team, and made a questionnaire and something like this, and I send my team together with me. So let's go to the home one by one and ask them that, do they know that what is hepatitis, what is hepatitis B, what is hepatitis C, how they affect, how they can be saved. So we come to the conclusion that even people were so ignorant that they don't know this disease, and they were suffering from it. And the day we come together as a research, I made a pilot project, and then we helped them to get in one place, and we tested, and almost 80% we get everyone who was hepatitis B patient with us. And I made this all together because there was a competition, entrepreneurship project competition research through the British Council. So I presented that we need to work upon this, because people are so much ignorant, people are dying, people are ignorant about it. So we need to stop. This is the need of an hour. In this way, me and my team has went to the many cities, many towns, many villages, and we start from here that we should start first, let them know what is hepatitis, and then we can cure them. So then we made the model. We made the model like this, that what is curative steps, that how we can cure them, and what are the preventive steps, how we can prevent them to from this. And then we found that the barbers are so much involved because they were using the one razor to the 10 people. They are using the same things to the same to the number of the people. Then we went to the barber association and we told them that we need to organize our awareness session so that we may help them to know that how they can save and how they can save their customers. So thankfully we have done this wonderfully, and now we reached the government as well. A government has a chief initiative program. They were running with the name of chief initiative hepatitis free Balochistan program. They were running, but they were saying that people are not coming. We have a medicine, we have a vaccination, we have so many things, but people are not coming to us. How we can give them these things? So then my team we have selected the slogan, talk, test, treat. So we will go, we will aware them, we will talk about it, we will tweet about it. I mean, we will go we will take our mobile team who will on the spot after the awareness session, they will take the test of the people that whether they are also suffering from hepatitis B or C. So in this way, this model helped a lot, and so many people come to us and we refer to them. We made the referral system. So we said we will refer to you the governments or to other organizations who are providing medicines or who are providing the vaccination so that you can be saved. So in this way, we saw that there is a great impact in the people. Even though now, last week I went to the two cities, Kila Saifullah and Muslim Bagh, and we done the same thing. We know that actually people are coming from Afghanistan. So we have so many people are involved in different kind of countries in different because we are living with very near to the borderline. So we know that when the people come from different countries or different cities, so then they are not vaccinated or not tested. So then they you can say spread these things. So now we have made our teams in 5 different cities, and now our team are getting to go shops, in bazaars, in the shopkeeper and the barber shops, in a very small people, in a very poor one. We went to the addicted one and we asked them that can we take your test. And suddenly, because I have passion, because my sister has died, so me and my team all together, we get together this fund so that we can do most of the time free of cost their tests if they cannot afford. So then we don't tell them that okay, you can go, but we say we can help you, no problem. If you cannot afford, we will do, but if you can support other person for the hepatitis kit, for that we can we use the combo kit that so that we can test upon the place. So in this way our organization is helping, and now on 28 in July we are expecting to meet so many organizations, to meet with them so that we can accelerate this, and we can take their help so that we can go to many places so that the people may get aware about it. And it is astonishing for me as well that how my sister has went as she died. So now it is day by day, there is a passion inside of me that I will not let her die. Thank you so much for listening.
Shaman, thank you so much for sharing your passion today. And I'm so sorry about the death of your sister, but gosh, what a lot of good that you've done, taking that passion for good and really taking it, taking the services that they need to the people and identifying gaps and reasons why, people aren't testing or whatever, and doing something about it. So, congratulations on the incredible work that you're doing. There was just a quick question from Louisa saying, asking if you said that in Pakistan, there's no possibility of liver transplant. Is that true?
No, now it is possible. Before 2010, it was not possible. Now there is some kind of big organization like Aga Khan University or some of the organization. They have started this now. But now it's possible. Now, yeah, it's possible. But it's better that we can save people that they may not go this stage.
Excellent. Thank you very much. And again, if anyone has any additional questions or comments, please put them in the chat. But since we have just 15 minutes to go, I am going to move on to the final section, which is really looking at how we kind of accelerate action through looking at things maybe from a different angle, whether that be from integration with other services or maybe through universal health coverage. But I think first we'll start with Gonzalo Lobo, and he's the regional director for the Fast Track Cities program in Europe. And Fast Track Cities is well, maybe I'll let Gonzalo explain it. He can do it better than me. So Gonzalo, please.
Thank you so much, Kerry. Yeah, so the Fast Track Cities initiative is an initiative led by UNAIDS, by the City of Paris, by UN Habitat and IAPAC. We are the technical core partner in this initiative. It began in 2014, and we want cities to act as accelerators to eliminate HIV, viral hepatitis, and TB according to the UNAIDS goals, and also the WHO goals, and also more broadly the development sustainable goals also. So what I really wanted to focus on, and rather than giving you answers on how you should deliver care and how you should test, just give you some insights of what is being done across Europe, the European region, which is the one I'm focusing. And it's really what we saw, and picking up on what we should learn from COVID-19, and also seeing the impact that COVID-19 had on needle exchange programs, on low threshold programs, and also on access to treatment. So we know that there is a large threat to viral hepatitis with the new COVID-19 pandemic. What we saw across the region is there is a huge decrease on low threshold programs, as I said before, and also needle exchange program and harm reduction. I will try to speak more slowly since we have interpretation. So one of the key aspects that we saw across the region is knowing, of course, your epidemic. And this can be a discussion for years and years within itself. We are not trying to say you should have already a robust surveillance system set up, but there are some studies that you can conduct just to know which are the groups that you should focus your intervention on. Is it key piece, or are you already looking in a more general and broader population in terms of the viral hepatitis screening and treatment? Then, of course, this takes us to the discussion of having this notion of micro or national-wide elimination of viral hepatitis. What we saw is mostly in the European countries, people are looking into having micro elimination programs, either key specific or region or city specific, so to speak. But this takes us to another discussion that leads us to are programs cost effective when they are looking only into one infection. So we see across Europe, there are a lot of programs that are financed only for Hep C or for Hep B, and they don't use this testing or the screening session to be cost effective and actually screen all through the other infections as well, namely HIV, syphilis, gonorrhea, etc. So we are looking rather into diseases and infections than looking into the person that we have in front of us. So it's really what we advocate for is really making the testing session cost effective. So we look into the risk factors of a person that is sitting in front of us, and we recommend the testing accordingly to those risk factors. Then a discussion that is also being conducted across the region is, are we having a public health approach, or are we having a more clinical and patient-centered approach? And this is not a one or another discussion. This can, of course, be integrated, but where you put your weight in, this will have an impact on the activities that you are going to perform. From a public health perspective, of course, you want to break the chain of transmission. if you look rather into a more patient focus or from a clinical point of view, then you are more concerned in long-term health of that person. And as you all know, financially, this is a struggle for all institutions and organizations that work in the field. So the money isn't there to perform either to perform all the range of activities. So sometimes we have to choose one or the other. What I also wanted to highlight is also the discussion that we are having. We have this notion of linking people to care. And this brings us to a notion that's completely wrong, what we believe, because well, the healthcare services are already there to serve people. So it's not linking people to care, it's actually linking healthcare to people. So we have to see this from another perspective and not pushing key Ps or other populations to go to health facilities, but actually encounter mechanisms that make healthcare accessible to these key populations. Well, this takes us then to the discussion of having low threshold programs, of course, especially in PWOODs. This is happening across, well, the whole Europe, but more focused in Central and Western countries. In Eastern countries, we still struggle with the drug policies that prevent some harm reductions programs actually to be run through. And this was also pointed out by some participants. Of course, this also takes lastly to discussion of preventing death. Then I would bring two examples. One is from Spain. So in Spain, there are two projects going on. One is the Hep City Free Manifesto that is inspired by the Fast Track Cities initiative, and where mayors of the city signed a manifesto on eliminating Hep C until 2030. And they conduct, very similar to the Fast Track Cities initiative, an all multi-stakeholder group that thinks the strategy for the city and comes up with a program to deliver the activities on the elimination of Hep C. And they have also another project going on the northern region of Spain, which is based on the one-time single consultation where you perform rapid tests, PCR confirmatory test, and the person goes out there with the treatment already prescribed and takes already the pills. So you know you're not going to have drop out of care, or you're going to have problems with linkage of care or anything else. And lastly, but not least, of course, bringing viral hepatitis onto the political agenda. And this is something that we are all struggling with, but this needs to be addressed. And I believe that COVID-19, and also with the advocates for making COVID-19 vaccine a people's vaccine, this should also be a fight for the Hep B vaccine. So the coverage is still very low in some countries, and we really need to, well, to ride the wave of COVID-19 being a people's vaccine, also for the Hep B vaccination. That's all on my end, and looking forward to your questions. Thank you.
Thank you so much, Gonzalo. And I really love the phrase, linking healthcare to people rather than linking people to healthcare. That's so powerful and so true. And I think that's, something that's really resonated across many of the to our final featured participant, but there's some great discussion and questions in the chat, which I think everyone should please read. I think there's Petra had some interesting things to say about how stigma impacts how HIV and Hep C screening can be integrated in her experience in the UK. Also a comment about hepatitis C self-tests. And the WHO guidelines will be launched around HCV self-test this month, so hopefully those are on the way. But I would just like to bring in now Maria from Argentina to really talk about universal health coverage. And this is a topic that's really on the top of the World Health Agenda at WHO and the United Nations. And it's something that us as hepatitis organizations and hepatitis advocates have to be aware of and really understand how to engage with and how to leverage. So Maria. Please introduce yourself and we'll be happy to hear from you.
Muchísimas gracias y muchas gracias por la posibilidad de traducción de este seminario que realmente súper interesante.
Maria, could you please sit a little closer to your microphone, please?
¿No se escucha?
Wait. Ahora, ¿me escuchas bien? Perfecto. Quería agradecer desde esta posibilidad de participar en este seminario y agradecer la inclusión de la traducción que realmente abre el espectro y posibilita la participación de muchas más personas. Realmente he escuchado ponencias increíbles en el día de hoy y siempre me emociona. Nosotros trabajamos desde hace 20 años. Yo soy presidenta de la Fundación HCV Sin Fronteras, una organización con base comunitaria realizada por pacientes, con muchos colaboradores, desde la experiencia personal también de mi marido con hepatitis C. Pero comenzamos en el año 2000 con un periódico que actualmente sigue online, que es Hepatitis 2000. Y trabajamos en estas dos cuestiones que se han planteado aquí. El ayudar a la persona enferma y trabajar por el cambio de políticas públicas para que esa ayuda que nosotros podemos hacer en forma particular pueda llegar masivamente a toda la población en nuestro país. Entonces, desde esos dos objetivos que empezamos a trabajar inicialmente, hoy creo que, bueno, se pudieron gestar programas, en 20 años se ha evolucionado tanto, ¿no? En el tratamiento, en mi país el tratamiento para hepatitis B es gratuito, el tratamiento para hepatitis C también, el acceso a la atención pública es gratuita, hay planes y programas, pero la dificultad actualmente sigue estando en el subdiagnóstico. Menos del 10% de las personas que se estima están afectadas por hepatitis B o C están diagnosticadas. Entonces, ¿esto a qué nos lleva? A seguir trabajando y profundizando en las políticas públicas, porque nosotros podemos continuar haciendo diagnóstico como seguimos haciendo con tamizajes gratuitos desde organizaciones de sociedad civil y trabajando con otras organizaciones de sociedad civil, pero necesitamos que estas enfermedades subdiagnosticadas tengan un trabajo específico desde las políticas públicas. Se profundice este programa. Entonces encontramos que hoy en Argentina y en el mundo la incidencia política que se puede hacer a través de cobertura sanitaria universal es el trabajo que las organizaciones de sociedad civil debemos incluirnos, porque es allí donde se han hecho los compromisos internacionales de los países y es desde allí donde vamos a poder cambiar para que estas políticas lleguen a todos. Entonces, quisiera también pensar en la definición de lo que es la cobertura universal de salud. Entonces, ¿qué busca la cobertura universal de salud? Busca garantizar que todas las personas en todas las partes puedan acceder a servicios de salud esenciales, de calidad y de manera accesible, sin tener que pasar penurias financieras para pagarlos. La cobertura sanitaria universal es una de las metas que se fijaron los países que adoptaron los objetivos del desarrollo sostenible en el año 2015, y que los países reafirmaron este compromiso en la reunión de alto nivel de la Asamblea General de Naciones Unidas en el año 2019. Y se estableció que los países que progresen en el logro de la cobertura sanitaria universal también van a avanzar hacia los demás metas relacionadas con la salud y los objetivos del desarrollo sostenible a los cuales se han comprometido. Entonces, ¿cómo integramos cobertura sanitaria universal con las hepatitis virales, que es el objeto que más nos ocupa en este momento? La meta 3 del objetivo del desarrollo sostenible es especialmente en este punto, porque hace un llamamiento a adoptar medidas específicas para combatir las hepatitis virales. O sea, los gobiernos se han comprometido a llegar a esta meta. ¿Y de qué manera la Organización Mundial de la Salud utiliza 16 servicios de salud en 4 categorías como indicadores de que se está llegando a esta meta? Y dentro de estas categorías están las enfermedades infecciosas, donde está contemplado el tratamiento para las hepatitis. Los gobiernos se comprometieron a dar tratamiento para hepatitis a través del Objetivo del Desarrollo Sostenible. En salud reproductiva materna e infantil, se ha comprometido a la vacunación infantil completa. ¿Qué incluye? Incluye la vacunación para hepatitis B. Y con eso vamos a reducir significativamente la incidencia del cáncer de hígado. Los gobiernos se han comprometido a esto. En enfermedades no transmisibles, trabajar para el control y tratamiento de la presión arterial, donde las personas afectadas por hepatitis virales también tienen afectada muchas veces la presión arterial. La prevención y tratamiento de la glucemia. Acaba de salir un artículo publicado sobre esta incidencia de la glucemia, de la diabetes 2, en las personas con estas enfermedades de hígado. Entonces también los gobiernos se han comprometido a esto, la detección del cáncer. Entonces estamos encontrando el marco por el cual hacer una incidencia real y política dentro de esto. Y la cobertura sanitaria universal, como dijo, viene a unir y a fortalecer el sistema de salud. En el año 2017, el doctor Tedros, director general de la Organización Mundial de la Salud, hace un llamamiento a los países para que integren los servicios relacionados con las hepatitis en los paquetes de prestación en contexto para hacer este esfuerzo de la cobertura sanitaria universal. Porque solos y aislados es mucho más difícil. Necesitamos fondos, y hay muchos programas que ya tienen fondos y podemos incluir, inclusive en atención primaria de la salud. En mi país hay un programa del gobierno que se llama Remediar, que da medicamentos gratuitos a las personas sin recursos. Ese programa también abarca la prevención en atención primaria. Dentro de ese programa tiene muchos fondos, recursos. Entonces, a través de ese programa estamos involucrando la atención primaria de la salud para la prevención de las hepatitis virales. Es encontrarle la vuelta y unir estos programas. Uno de los conceptos claves de la cobertura sanitaria universal es fortalecer los sistemas de salud. Y esto se define como una iniciativa y estrategia que mejoran las funciones de salud. Los pacientes somos un papel esencial, las organizaciones de sociedad civil, para garantizar que los gobiernos lleguen a este compromiso. Y también la eliminación de la hepatitis viral es algo clave en los programas de cobertura sanitaria universal. Y yo quiero mencionar cómo integramos estos programas en Argentina, de qué manera la experiencia nosotros nos sumamos a cobertura sanitaria universal. Hicimos un primer debate, primero, unirnos con otras sociedades civiles, como decía Yamon, juntar sociedades civiles vinculadas a otros problemas de salud, pero más allá también, medio ambiente, por ejemplo, también están unidos con los problemas de salud. Porque solo las organizaciones de hepatitis virales hemos hecho mucho, y la incidencia política nos ha llevado también a estar en este posicionamiento a nivel global. Que esté la Declaración Política Universal en Derechos Humanos, que esté cobertura sanitaria universal, también es incidencia política de la sociedad civil, que eso va a llegar a los pacientes. Pero vemos que en cada país, para que se cumplan, tenemos que unirnos con otras organizaciones. Entonces, en Argentina, en el año 2019, organizamos el primer debate de la sociedad civil para trabajar en cobertura sanitaria universal. Estuvimos con el apoyo de ONUCIDA, de la Cruz Roja y Media Luna Roja, con OPS, trabajando en esto, haciendo un debate y un taller de qué era lo que entendían las organizaciones de sociedad civil en nuestro país por cobertura sanitaria universal. Y a partir de ahí, de sus causas particulares, cómo podíamos encontrarnos para poder lograr estos objetivos. Entonces, también la COVID-19 nos ha enfrentado a una crisis sanitaria sin precedentes. Entonces también, en el año 2020, hicimos un llamado en nuestro país al Poder Ejecutivo, al Poder Legislativo, al Poder Judicial, al Parlamento y a los diferentes sectores para saber de qué manera estábamos enfrentando esta crisis y caminando hacia los objetivos del desarrollo sostenible y la cobertura sanitaria universal. Y fue organizado desde sociedad civil, y hubo participantes de alto nivel, como referentes de la Comisión Económica para América Latina, de la Comité Económica de Salud, desde el Ministerio de Salud, participaron los que tienen que ver con equidad en salud. Se hizo 4 ejes temáticos. Organizaciones de la sociedad civil participaron en planificación estratégica para alcanzar esta cobertura sanitaria universal, porque la sociedad civil tiene que estar involucrada para lograr estos cambios. Entonces, de este lugar y formando redes con otras organizaciones de sociedad civil, a mí me gustaría, nosotros trabajamos en esta capacitación en otras organizaciones vinculadas, como les decía, trasplantes, diabetes, riñón, VIH, hacemos trabajos en conjuntos para fortalecer, incluir en estos programas a nivel de un gobierno y de salud, y por el otro lado la sociedad civil más unida y trabajando cada uno en sus causas, pero todos juntos en este acceso a la salud real, ¿no? De tratamientos, de que no cueste el dinero de bolsillo una atención básica para la salud. Y mi pregunta quizás, para todos los que están escuchando, me gustaría saber si consideran que fortalecer el trabajo de la sociedad civil en su país, en cobertura sanitaria universal, sería una estrategia de incidencia política para avanzar más rápidamente hacia la eliminación de la hepatitis viral. Esa pregunta me gustaría escucharlos, a ver cómo la consideran en sus países. Gracias.
Thank you so much, Maria. And it's such an important topic about how we look at hepatitis within the, the whole health system, and how we find our role and make sure that hepatitis is actioned, but is also part of the bigger picture. And I think that's such an important thing for us to think about and consider. So thank you so much for that. We are a little bit over, so I'm just going to address a couple of questions in the chat. If you had any comments for Maria's final question, please do put it in the chat, and then we'll save those and make those available afterwards. But there's a couple of things that people put in the chat that maybe we don't have enough time to address, but maybe if people would like to talk about it afterwards. Antonio brought up a very interesting point about the language that we use around hepatitis and whether different terminology might be better. And I think it kind of highlights, just for me, the whole issue of that language is important. The language that we use is important. How we describe people living with hepatitis is important. So I think that's always something to consider. And second, there was a question about whether there's a strategy in place to speed up hepatitis B vaccinations globally. I mean, Gavi, the Global Vaccinations Alliance, does have a plan to support birth dose vaccination, which was put on hold when the COVID crisis began. We just sent an open letter signed by over 300 organizations to Gavi, asking them to action this now, not to wait any longer, that hepatitis can't wait until the end of this. And there are signs that they are going to restart that program again. I believe they've hired someone for a dedicated post, and things are slowly starting to move. So, I mean, if Gavi reinitiates their birth dose program, that would be a huge step forward. Countries will still have to pay for the actual vaccine itself, which in most places is about 20 cents, I think. But all the wraparound will be included in Gavi, and it has a really significant budget. So fingers crossed that will happen. So I'm afraid we're just going to have to wrap up. It's been such an incredible 69 minutes. I think the passion that's been from all of our speakers, and that's evident from the chat box, is just so inspiring. And we kind of heard about, why do we accept that 1.1 million people are dying every year? Why aren't governments more motivated to act? And I think a lot of that has to do with the kind of stigma and discrimination that hepatitis organizations face. And of course, us as civil society organizations have a big role in combating that. And I think it was interesting what Sione said about kind of prioritization that the people that we want to serve have, and that for some people actually, you know, hepatitis is not the number one concern. It might be food or shelter, or you know, if they have needs around their addiction. So that again kind of reinforces this idea about bringing services to the people, you know, going where they are, not expecting people to come to our needs, not expecting the people that we want to serve to have exactly the same priorities that we have, but understanding that and then working with them to improve their lives and well-being. I think that's such a powerful message. I think, you know, finding the niche when you're dealing with a huge situation that Manal said, when you're looking at a huge need, finding that niche to start with, I think is so important. And of course, Shimon, just really kind of being relentless in identifying the gaps in his local area and finding ways to bridge those, I think is just totally incredible. And I think, you know, this conversation around universal healthcare and integrating with HIV and TB is such an important one. And I think we had some really great insights on how that can work and how that can go forward. So I think it's been a great first global discussion. I've learned so much today. So I'd like to thank everyone who contributed, everyone who attended, everyone who spoke so eloquently. Just to remind you that we have 2 more dates for the diary in this month. On the 20th of July, we're going to have Policymakers Can't Wait, which is going to be another roundtable discussion with decision makers and civil society members, really talking about, you know, what is the problem? Why are governments so slow to act on hepatitis? You know, is it because it's too expensive? Is that the real reason? Is it because of stigma? You know, are there other factors, and how can we work together to overcome them? So I think that's going to be a really insightful session. And then on the 26th of July, we have Youth Can't Wait, which is the first time we've really had a session dedicated to youth and the voice of young people. So many people, you know, were infected or, you know, acquired hepatitis at birth. And I think the voices of young people affected by viral hepatitis and the people working with them need to be a lot louder in our community and into the world. So we hope this will be a good first step in that journey. So thank you all so much for your contributions. And I really hope we see you at one of the webinars later in the month. So thank you, and goodbye.
Gracias.